Hello, everyone. My name is Edgardo Rivera. I'm an MD from Sherman College of Chiropractic. I would like to introduce the beginning of the anterior and superior mediastinum for a board review. So I'm going to start passing some slides for you guys, and I will go over some of them so you can take notes or just be aware of certain structure that you need to recognize and see the difference between them. And let's start. In the first slide that we have is the anterior view of the thoracic skeleton. The anterior view of the thoracic skeleton is showing us the following things that you need to remind. You have 12 pair of ribs from 1 to 12, and you're going to have in the thoracic rib cage, you're going to have 12 vertebrae. So you have from T1 to T12, plus the 12 pairs of thoracic ribs. In the superior part of the thoracic cage, that's another name that you have over here, you have the superior aperture of the thorax, or the superior thoracic aperture. There also, we can call it there the thoracic inlet. It's another name they have. So you have the superior opening of the thorax, called the thoracic inlet, and we have the inferior opening of the thorax that's going to be happenings over here. So you have a superior opening and inferior opening of the thoracic apertures, but the superior one, that we call it the thoracic inlet, there is a condition that we call the superior thoracic outlet syndrome, or thoracic outlet syndrome, in where they change the name, as you can see or read and listen, and where they change from thoracic inlet to thoracic superior thoracic outlet syndrome. And this is very common. It can happen, and it's going to happen in the same area that we already have been marking red superiorly. The thoracic or rib cage is made by 12 pairs of ribs and 12 thoracic vertebrae. Ribs have another name in Latin that we call the costa. So if you listen to the costa, means ribs in Latin. Important for you to know is that from rib number 1 to rib number 7, they are called true ribs, and from rib 8, 9, 10, 11, and 12, they have a different name, and 8, 9, 10 are called the false ribs. So the first 7 pairs are called the true ribs. The 9, 10, and 9 and 10, 8, 9, and 10 are going to be called the false ribs. And the reason we call the false ribs is you're going to see the costal cartilage or rib cartilage is going to be, they're not going to end the ribs with their own costal cartilage. They're going to be independent. So from rib 1 to rib 7, they have their own costal cartilage directly attached to the manubrium, to the body of the sternum. And when you go to 8, 9, and 10, they're going to come together, and they're going to end in the costal cartilage of rib number 7. That's the reason that we call the false ribs. Rib number 11 and rib number 12 also are called the floating ribs. And the reason that we call the floating ribs is because those two ribs are not attached to anything in the manubrium via any cartilage. So they are going to be alone. Be aware that the true ribs 1 to 7, the false rib 8, 9, and 10, and the floating ribs 11 and 12, 11 and 12 also can be named as the false ribs. So you can call the last two, 11 and 12, floating ribs or false ribs. 8, 9, and 10 can be called as the false ribs. Thank you. This slide is going to show you in the thoracic cage. Again, we are talking about the superior thoracic aperture, in where we have been already highlighted the borders of the thoracic inlet. Remember, superior thoracic aperture, the other name is thoracic inlet. So you can see that we are going to, we mark already the borders of the manubrium, the superior border of the manubrium. We highlight also the costal ribs on rib number 1. We highlight the medial border of rib number 1 until we reach the body of T1 and continue with the superior medial border of rib number 1 in the right side, and then we continue with the costal rib and end with the manubrium. That space that we have, or that apertures, is the thoracic inlet. If we go to the inferior thoracic aperture that we have already highlighted in red, it's important that you be aware of that, because we are going to have the following structure that you need to be aware. So the space that you have between the xiphoexternal, the xiphoid process, and the inferior border of the ribs, we call that space the subcostal angle or infraexternal angle of the thoracic cage. And all the highlight in the inferior aperture of the thoracic cage, remember that red highlight that we have, including the costal margin that are in outlined, the place that we see there, or the structure that we have been already highlighted, means that the diaphragm is going to be attached to those places. So the diaphragm is going to be attached inferiously to the subcostal, to the costal margin, to the costal margin. We are seeing in these slides a posterior view of the thoracic cage, and what is very important that you must be aware is that the red line that we have been traced over the ribs, going from rib number 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12. Why I didn't include the rib number 1? Because from 2 to 12, we are showing you the angle of the ribs. And rib number 1, because it's an atypical rib, doesn't show up or doesn't have an angle of the rib. What is important with that costal angle? The costal angle means it's the place in where most of the rib fractures occur. So most of the rib fracture occur or happens in that angle. And that angle also is aligned. Repeat, this angle is aligned with the medial border of the scapula. So if you look on the right side, you're going to see the scapula over the ribs, and you're going to note that the scapula, the medial border, is in the top of the angles of the ribs. And remember, the question on the board can happen in what place most of the rib fractures occurs. Thank you. This is a view of the sternum. The sternum is a long flat bone that articulates with the clavicles and ribs. Be aware that the rib notches are going to be in a joint with other bones, for example, with the ribs. But in the case of the jugular notch that we have superiorly in the manubrium, that notch have no articulation with any other bone. So you're going to realize that we have the the jugular notch, and then lateral to that we are going to have the clavicle notch. And then inferior to the clavicle notch, you're going to have the first rib notch. Immediately below, you're going to have the notch for rib number 2. Rib number 2 that is going to happen in the angle of Louis, or sternal angle. What is very important in this angle? So we have in the center a view of the angle, because the only way that you can see the angle is if you have the sternum and have a lateral view like this one. And in that way you will be able to see the sternal angle of Louis. What is important to that angle? The angle of Louis is important for the following. The transverse thoracic plane runs from the angle of Louis posteriorly to the inferior border of the body of vertebral body inferior border of T4, and the superior border of the body of T5. So from anteriorly to posteriorly, you're going to have the transverse thoracic plane that is going to divide the thorax, and it's going to be a landmark that you need to be aware. Remember that when we talked about the thoracic inlet, we discussed the borders that makes the aperture, the superior aperture of the thoracic inlet. And here we have another landmark that is important that you be aware of, that we call the transverse thoracic plane. In the case of the xiphoid process, of the sternum, we are going to have between the xiphoid process and the body of the sternum, we are going to have a xipho external joint, and that is going to mark a line anteriously between the xiphoexternal joint and posteriorly to the superior border of T9 vertebra, of T9 vertebra. And I don't want to finish in this slide without mentioning the following. In the manubrium, you're going to have notches, rib notches, for the first 7 ribs, from rib number 1 to rib number 7. And be aware that that means that those are the through ribs. Okay? So once you see the manubrium and the body and the xiphoid process, the notches that you have are going to be for the true ribs in the body. Thank you. In this slide, you're going to be able to see a typical rib. In this case, they're showing a typical rib. And the typical rib is going to show the following. You're going to have the superior articular facet for vertebral body. You're going to have inferior articular facet. You're going to have a head of the rib. You're going to have the neck. You're going to have the tubercle of the rib with an articular facet for the transverse process of the vertebra. You're going to have an angle of the rib, and you're going to have a body, and you're going to have inferiously, you are able to see the costal groove of the rib, the costal groove of the rib. Remember, the costal groove of the rib is going to have and show up in the cadaver or in the living person. Is going to contain the vein, the artery, and the nerve that's going to run inferiously to the vertebra from posteriorly to anteriously. Continue with the ribs. In this case, we are able to see rib number 1 and rib number 2. Rib number 1 and rib number 2 are atypical. Repeat, are atypical ribs. From rib number 3 to rib number 9, you have typical ribs. Rib number 10 and rib number 9 is known as a false rib, and rib number 10 is a false rib, and 11 and 12 we know as floating ribs, or also we can call it the false ribs too. And the difference is because they don't have all the structure that we have seen in the typical rib that we saw before. For example, you can see in rib number 1, you don't have an angle of the rib, for example, and only you have an articular facet with the vertebra in the head of the rib. You're going to have only one articular facet. In rib number 2, rib number 2 has two facets for T1 and T2, but that rib also doesn't have an angle of the rib. The body is flat, and it's going to be flat from superior to inferior. And the same happened with rib number 1. Normally the ribs are going to be more vertical than horizontally. So rib number 1, rib number 2 are going to be more wide and flat, and then the rest of the ribs are going to be more vertical with superior border and inferior borders. Rib 11 and 12 only have one head, and they are not going to show the structure that you can see in the typical ribs normally. Thank you. We are looking at the vertebral column in these slides, and just a reminder, guys, that you need to be aware of how many vertebrae you have per section or by region. The first one is the cervical with 7, thoracic 12, lumbar 5, sacral you have 5 fused together, and the coccyx is going to be between 3 and 5. Important in the lateral view that you can have of the vertebral column is realize that you have two different type of curves or convexity. In the cervical and lumbar region, you're going to have a lordiosis. That means it's convex anteriously, anteriously, and you have the thoracic and the sacrococcygeal area with the kyphosis. The kyphosis means a concave anteriously. We also are looking at the two vertebrae at side, and where we have only 1 and 2 together. So let me go there and show you what is important to know there. This is the vertebral foramen. Vertebral foramen when you have only one vertebra. When you have the spinal cord, or you have the when you have the vertebral column together, we call the vertebral canal. Vertebral canal. So change from vertebral foramen to vertebral canal. And then we have two vertebrae, one in the top of the other. So they are showing you that we have intervertebral foramen, and where we are going to have the spinal nerves coming through. So we have the intervertebral foramen. If we remove the one on the top, we are going to have two individual vertebrae. So we are going to have, instead of intervertebral foramen, we are going to have a inferior or superior vertebral notch. So is this will be alone, this space here will be the inferior vertebral notch, and the one at the top will be the superior vertebral notch. Once they are coming and being together as these two, you're going to have a intervertebral foramen, and that's this is the place where you're going to have the spinal cord is coming through. Continuation of the vertebral and landmarks that you need to be aware of. We have in this lateral view of T6. It's something that we have been talking before. Remember, when you have individual vertebra not attached or articulated with another superiorly or inferiously, remember that we have the inferior vertebral notch over here, and we have the superior vertebral notch. When you have two or more vertebrae together, they change from inferior vertebral notch, and they becomes to be the intervertebral foramen. Intervertebral foramen, but they are one alone, without one in the top or one inferiously. They becomes to be the inferior vertebral notch or superior vertebral notch. You have the same. This one the inferiously, and the one in the top of the other are going to make the intervertebral notch. Remember, inferior vertebral notch, when you have more than two or more together, they becomes to be the intervertebral foramen. Also, inferior left, you have three vertebrae. So you have T7, 8, and T9 together, and this is a posterior view. What they are showing you is the vertebral canal. So when you have more, when you have the vertebral column together, you're going to have a vertebral canal. You're not going to have a vertebral foramen. So in the top is vertebral foramen. Down, where you have several vertebrae together interacting one in the top of the other, so you're going to change the name to vertebral canal. The part of the vertebra and the specific structure that you have in each one, you need to know, and it's part of your evaluation of the material that you have. But I just want to bring to your attention things or topics that I understand that you need to be aware and trying to be prepared for your test. Thank you. Hi, this is the last slides for this section, and I would like to show you two different pictures. The one in the left is showing you the thoracic cage, and show that provides a complete wall peripherally. But remember that it's open superiorly and inferiously. The superiorly aperture that you have, we call the thoracic inlet. of superior thoracic aperture. And the inferior is going to be called the inferior thoracic aperture. The borders that you have in the thoracic inlet are the T1 vertebra, the ribs number 1, the costal cartilage for that vertebra for rib number 1, and the superior manubrium. The superior border of the manubrium also is going to be part of. And the inferior thoracic aperture boundaries are the following. T12 vertebra, ribs number 11 and 12, the costal margin formed by the costal cartilage of rib 7 and 12, the cephosternal joint and the diaphragm attached at the inferior thoracic aperture forms an almost continuous barrier between the thoracic and the abdominal cavities. As I mentioned, you can think about the diaphragm is going to be the floor for the thorax and the ceiling for the abdomen cavities. So remember that many structures pass through these apertures and forms the thoracic and pelvic cavities. The pelvic cavity is going to have two portions. One is going to be in the abdomen that we call the false pelvis, like going from the pelvic inlet or the pelvic brim to the superior border of the crest or the iliac crest. So that part is the false pelvis. Once you reach the pelvic brim or the pelvic inlet down to the pelvic diaphragm, that's the space that we know as the true pelvis in the male and the female. So if we move now to the picture in the right, again, I'm sorry that I'm going to repeat this again, but you need to be aware that you have the superior thoracic apertures, and you need to know the borders that makes that aperture that you have superiously, and the inferior border that makes the inferior aperture of the abdomen, of the thorax. So thank you.